representative or a lay member of the governing body to be nominated as part of the EP or assurance. I think in reality that's much more pertinent for provider organisations and level 1 responders. We're a level 2 responder, but as it stands, that requirement is still something that we need to be able to indicate that we've identified somebody for that. So I will progress that through the senior management team. And the other elements within it are very much on track. So I'm pleased to say that we've got a high level of assurance received from the NHS England feedback, and I'm happy to take any questions.
Thank you very much. Any questions from members of the governing body on this item? Okay, this is for approval and note, so I think we can take it as noted and approved. Okay.
So there is one other element which is just about supporting the requirement for inclusion in our annual report. Again, that's a new part of the standards. It's not previously been captured within our annual report. But if it's acceptable to the governing body, I'd like to include just a couple of lines within that annual report indicating the outcome of this assurance process, which will give us a higher level of assurance next year that we actually did it, would one believe.
Okay, Tony is nodding, so yeah. Thank you. Thank you. Right. Moving us on then to item 2.6, the Board Assurance Framework Summary.
Thank you, Chair. So you have in front of you the Corporate Risk Register and the full Board Assurance Framework, which we bring to the governing body for information twice a year. Our Joint Executive Management Team provides scrutiny of the BAF on a monthly basis, and each of our subcommittees considers the risks pertaining to its agenda at every meeting. We currently have 31 risks on the Richmond register, and 3 have been identified as very high risks, and those are around the achievement of our financial recovery plan, as well as the achievement of our QUIP targets. There's currently a risk management audit happening across the 5 CCGs in South West London, and we'll get the report on that later this month. Our auditors recently did a benchmarking report, and that didn't highlight any concerning issues around the way we manage our risk and board assurance framework, and we had feedback that we are making improvements in the way we do this. And we have recently recruited a governance and business officer, and a key part of their role is to support the management of the 4 risk system and to work with each of the directors on making sure that the BAF is up to date. I'm happy to take any questions about the risk register or the BAF.
So any questions on this item for Vicky? I mean, has anything substantially changed since we last met?
No, and I think we're consistent in our highest risks.
Okay, thank you very much. So noted by the governing body. I'm going to keep us moving forward then. Item 3.1, quality, safety and performance. Fergus again.
Thank you, Chair. So this is a familiar report to the governing body, which contains the latest performance assurance report, the operating plan and supporting activity metrics, our latest improvement assessment dashboard, and our quality premium dashboard. And also within that, this report at the rear of the document includes the South West London level performance report as well for the committee to note. So these reports are a summary of what was discussed at the 20th of November and 18th of December quality, safety and performance meetings. I think the 3 main areas that I would want to draw the governing body's attention to are listed on the second page of the covering paper. So as Tonya has mentioned earlier, accident emergency performance, it is a key feature. We've talked about it previously in terms of our winter plan and preparedness. We're now very much in that period of time. whilst the system is not delivering the expected performance at the 95% standard, we are very close to it. We are performing and holding up quite well winter to date. The CCG is providing daily support and assistance to the system, both with local authority partners and community providers to support the flow of patients both in and out of the hospital. And I think overall, I think we're performing as we expected. I think we anticipated we weren't going to hit the target, but we wanted to make sure that services were very much safe and effective. And I'm pleased to say that performance so far has been pretty good, I think, overall. The referral to treatment waiting list size we've talked about, and there is a further paper that Galini is going to talk to, and this is the requirement for a waiting list size at the beginning of the year to be, at the end of the year to be no bigger than the position at the beginning of the year. There are a couple of elements that are driving the failure to achieve that requirement. One is the increase in referrals, which has resulted in a higher volume of patients than we would have expected, and also some of the process around the waiting list validation and inclusion of patients into the patient tracking list numbers. But there is a more detailed report coming on that. And also the level of delayed transfers of care being higher than expected. As a system, we're performing well, but it is clear from the data that we're looking at now that there are a small number of patients in the mental health provider and the community trust that are disproportionately resulting in some increased delayed transfers of care. There's a very active programme of work and partnership across the system to improve that, and we'll continue to focus on that in the coming weeks and months. Within the actions at the beginning of the meeting, there was a query at the last governing body around the number of total elective admissions. And I think the underlying issue within that was that there is a data lag in terms of the reporting position and the actual position. This has caught up. So you'll see on page 8 now that our overall elective admissions figure is very much back on track. It's 1.5% difference away from what our operating plan was. There is still a difference between the number of day cases and the number of ordinary elective admissions, those who are admitted into beds. And I guess the two underlying issues that we've identified driving that discrepancy, one is actually something we had planned for, which is the effective commissioning initiative, which has reduced some of our elective activity. And the other is, as one would expect, a conversion of some previously inpatient episodes that are now being treated as day case episodes. So you'll see that while we've had a reduction in the overall elective inpatients, we've had an increase in the number of day cases. And the second part, or part B to the day case issue, is some of the activity that is transferred from other providers in South West London into the Kingston area, into Kingston Hospital, and primarily St George's to help with their waiting list position. So that is increasing the overall patient tracking list numbers at Kingston Hospital. At the back of the report, you'll see some of the feedback we've had from a variety of our clinical quality review groups. There is nothing within that I'm particularly concerned about that I'd want to draw to the committee's attention, other than to say that we did take the opportunity to conduct a tabletop review with senior managerial and clinical staff from South West London and St George's, and to look at the number of serious incidents that they have, the number of those that are open, and to just take a stock take as to whether there were any thematic underpinning issues or whether there were any locality issues, i.e. specific wards or specific teams. That's the only issue that I'd highlight from the clinical quality review group feedback that we had at the last two meetings. But I'm happy to take any questions if there are any arising from the report.
Thank you very much. There's a wealth of data in there. Does anybody have any overarching or even specific queries or questions? Sarah.
Sorry, yes, thank you. On the building relationships, and I think that has been an issue in Richmond and working in an integrated way, I would just reflect that I think that's come on leaps and bounds recently over the last few months. And I know that the leadership group for Richmond, which is some of the senior leaders across the system coming together, is really making progress. So I just wanted to say that. So there wasn't a great deal of information about that, but I do think that that will be reflected positively in the future.
Any
I just wanted to make a comment about, so in the draft quality premium dashboard about overall experience of making a GP appointment. I received a GP survey to my home address as a patient. The questions in the GP survey have not come into line with our different ways of working. So in terms of us using telephone triage, so the questions are very leading towards a face-to-face appointment, okay? And that's quite interesting that the national survey very much favours seeing the only way to have contact with your GP is face-to-face, when we are being pushed to contact more patients, and actually a lot of patients may not need a face-to-face, they can do telephone, so we're trying to bring in Skype, email consultations. So the GP survey seems out of kilter with actually the way we work. So sort of, you know, I'm not trying to defend my colleagues, well I suppose I am, but what I'm saying is actually the GP survey about experience of making an appointment, it's not entirely accurate, because a lot of it is done over the phone or in different methods rather than face to face, and the survey questions have not caught up.
Okay.
Basically, the messages that are coming from above in these GP surveys are not the messages, are not in line at all with the messages that we're giving and the way that we're trying to transform care of the NHS. And so, you know, it is confusing for the public to know how to use the services when we're trying to change them, but it's not being reflected in any messages given by politicians or anything.
I think we can note that and potentially feed it back, given the opportunity. The only other comment I was going to make was on page 8 about referrals, and I note that they're all negative against plan, and I'm aware there has been a considerable amount of activity going on looking at referral pathways and looking at kinesis and advice and guidance and other ways, and we know that outpatient referrals is something that's being highlighted in the NHS plan. So again, we're kind of on the front foot for that, that data would seem to say to me. Okay, if nobody has any further comments, I'm going to move us on to the Finance Committee and Yalini.
I can, before we just head across there, if I can just ask the governing body to review the elective activity update. That is the South West London paper that you have. Fergus has done a grand job of actually taking you through most of it, but it's something that we actually ensure that the governing body has had oversight and recognition that, as Fergus has mentioned, that whilst all best endeavours are in place to sustain the waiting list target to the March 2018 figures, actually it is becoming increasingly unlikely that we will achieve that, given where we are in terms of being in January at the moment. The financial impact of that is reflected in the quality premium schedule that Fergus has just taken you through, and you will see that we are not accounting, obviously, for achieving that, and therefore have a 50% penalty against it. But happy to take any questions on the elective activity report, but I think Fergus has probably done a grand job on that.
Okay, any questions for Yalini? This is page 177 onwards.
So if I can take you through the finance papers, I'm happy to do both of them together this time because they both reflect the month 8 position. We had a pre-Christmas finance committee where we took the month 8 finance position there. The report that you have actually shows that we knew that the plan that we had for 2018-19 was incredibly challenging, given that there was quite a significant level of unidentified CRIP of about 7 million. As the year progresses, obviously, whilst best efforts were there to reduce that level of gap, it's become increasingly unrealistic to report that we will come in on our surplus of 268,000. Therefore, at month 8, with the permission and the conversations with NHS England, we are now forecasting a year-end deficit position of 3.9 million. This position has been reported to you but been shown to you as risks. And if I can take you to the main paper, and you can see the risk and mitigation slide on slide 15, you will see that actually now there is a significant reduction in the level of risk, because now the current reported position has moved to the 3.9 million. If I can stick onto the risk and mitigation slide, I just want to draw the governing body's attention to the Chelsea and Westminster transactions merger payment. This was a payment that we had agreed to be funded by a different source, and there was an expectation that that source would come through North West London. We've been pushing for that, and we've invoiced for that last year, and we were pushing for payment of that. It has, however, arisen in the last month that possible mediation is needed to resolve this, and therefore, even though we had not included it before within our risks and mitigations, we feel that it is needed to be reported for this year, and hence on slide 15 in the table, you'll see that we've included that merger payment as part of our risks. So our total risk position is 1.25 million, which could mean that we could further deteriorate. However, we are working very hard in terms of looking at all other mitigations. We have you can see that the main pressures that we've had is in the acute area. I'm pleased to report that actually in late December we have now agreed a year-end position with Kingston Hospital that releases some of the seasonality provision that we had and gives us a bit of more mitigation and takes risks out of the system. I'm also pleased to report that for the Chelsea and Westminster we have gone with North West London and agreed an outpatient block, and actually we are seeing significant activity increases at Chelsea and Westminster for Richmond. So actually that is also de-risking the position. We are hoping that we'll continue to work to look at reducing the level of risk here and come in and deliver at the 3.9 million. We've also had some really positive work in terms of some of the non-acute activity that we've been doing. We've been working with Fergus's team with VHC and seen some real benefits there. We've also continued to work well with our prescribing teams, and prescribing is also showing significant savings, which is helping the position. I was going to stop to talk on 18-19, but I'm happy to take any questions there before I give you an update on where we are with 19-20.
Any questions or queries?
Just one question. Have we any indication of what the winter pressure has been like experience-wise yet? I mean, I know it's early days and it's probably anecdotal, but it would be sort of helpful just to have that in our minds.
So I think if we look at where we would see the pressures, we'd see it at Kingston and we'd see it at Westmid. So with Kingston having agreed a year-end deal, we have mitigated some of the risks there. There is significant risk potentially at Westmid. We are looking and working with North West London there in terms of some of their issues. We are not seeing a huge increase, and I haven't heard a lot of noise in terms of wait lists and A&E there. I don't know, Fergus, if you're able to offer anything else in terms of pressures that we're seeing.
No, so I would agree. I think we're hearing very little in the system from the Westmid and Chelsea side of things. On the Kingston side, as I mentioned earlier, we're providing quite a lot of support to them. I think think it's fair to say they're also operating on a significantly reduced bed base compared to last year, which is an output of the work that we've done in part around continuing healthcare, in part around improving our delayed transfers of care, and also our escalation processes and procedures. We've really tightened those up over this winter. And again, I think, and Sarah touched on it earlier, the partnership working within the system at the local level, I think it's working very well at that system leadership level, but actually those operational teams, I think, are much closer. So whilst there is some pressure within the system, I think we're managing it in a better way than we would have done in previous winters.
I just to agree that I just remind people I don't believe Kingston Hospital have opened any escalation beds, have they? So they haven't opened any escalation beds. And I met with Patricia at HRCH on Friday, and she had some very positive feedback from the actual step up that the Community Trust is doing using the TMH beds. So they're actually much more, not just a step down from hospital, they're using those beds to prevent people going to hospital. And the Kingston Hospital fed back that it was some of the most innovative work they'd seen, and a step-up approach to the HR. So I think I would reflect that it's. I mean, it's still, we're still not over the winter yet, are we? But actually, the way the system's working and the way we're using our resources differently. And I know with Liz and the social care as well, we've been working really hard to be proactive. So we are seeing a difference, but I think the fact that we haven't actually increased the physical capacity at one of our major acutes yet is a positive as well.
Sorry, just to add, Antonia, that was a helpful prompt to remind me, but also within the system we were concerned during the summer about the relocation of the Tolworth inpatient beds onto the Teddington site, because there was a reduction of 10 physical inpatient beds during that time too. So whilst we're also seeing about 50 less beds in the acute system, we also have a further 10 less community beds, and we still have the availability and the throughput for those to be utilised, and there's very little by way of delays in comparison to previous years. So, and that reminded me just to give some credit to the community teams about their reductions in beds too.
Just to add, because we do have a joint assessment team working in Kingston Hospital now across health and social care, and I've just received the detox stuff. Social care is positioned 11th in London for Richmond in quartile B, so we've really made big improvements, and we're continuing to make big improvements. And how we compare with others is really positive too in both health and social care. So I think we're in a good place, but I'm touching wood here because.
Okay, so that sounds all optimistic. Being a cautious doctor, of course, the flu season has only just started in the last couple of weeks, but
it's not really been winter yet.
On that optimistic note, we'll move forward. I have one question, Yalini. We started the year in deficit. You can almost see the finishing line now, and we're planning to end the year in deficit. Have we improved in year compared to last year?
So there has been a marginal improvement in our underlying position. I think the increases that we are seeing through acute need to be addressed, and I think the positive things moving forward into 1920 is a very different approach that we are taking with our partners, and we're working as a system. So despite the fact that we're very the actual detailed guidance hasn't come through yet, we are working with both our local authority and health partners to actually try and understand that system, recognising that there is a very limited resource, and trying to look at how demand capacity aligns into the finances as well. So I think that's positive. The other really positive piece of work in looking at the underlying position is the really good piece of work that we've done regarding CHC. So looking at the database, understanding the costs that we have there, recognising what is true, and recognising where the database needed to be reviewed because it was out of date. So I think there's some good pieces of work there, which we will continue to do into 1920. So we're a long way off, but I think we're heading in the right direction.
Thank you. So do we keep going?
We keep going. So the only other thing that I just wanted to mention is that despite the fact that we are still due the allocations today, hopefully, there is an expectation that we put in a activity planning draft on Thursday, the 10th. The positive thing about this, again, is because we're working as a system, there are two key things. One, the activity has to align to our providers, so commissioners and providers have to align. We've worked very hard with Kingston Hospital, and as host, we are aligned on that. We've been quite pragmatic in the approach that we've taken forward. So because the guidance has been delayed, we've taken a pragmatic approach to say, well, actually, if the emphasis is we need to be aligned, we'll take a pragmatic approach and we'll put in the same level of growth and savings. So actually we can then show to NHSIE that we are working as a system to take that forward. So that is going to be submitted on the 10th of January. And as soon as we get any real financial information, obviously we'll bring that back to governing body.
Okay, thank you very much. Any final questions or comments? Excuse me, for Yalini? Thank you very much. So, minutes for information and updates from subcommittee. We've got the Primary Care Commissioning Committee minutes. We've got a whole raft of policies for approval. And that have been approved. So do we need to do anything with those? Just for information. So everything else on the agenda is for information, unless I've misread it. I'm looking to the committee for help. Okay. Date of the next meeting is Tuesday, 5th of March, and that's going to be in Cole Court, so the other side of the railway line, in a slightly warmer environment. So, public question time. Members of the public present are invited to ask questions.